the ultrasound has become extremely popular, not just in rheumatology, but in most of the specialities in the recent past. There are many reasons for that. It's something which is available on the bedside, and it's easy, relatively easy to learn. It has a very wide application, and it is a safe and non-intervention investigation. It doesn't require any contrast. Can do things while you are examining the patient, so you get immediate answers. And it is very helpful in performing intervention. It's very commonly being used for nerve blocks by anesthetists. It's commonly used in ED to do cannulations, for chest drains, and for many of the procedures. In rheumatology, we use it for various types of nerve blocks as well as for joint aspirations and injections. It significantly improves the efficiency of the clinical process. So having an ultrasound by your side increases your decision power, reduces the number of visits the patient has to do to the clinic, and hence helps with the health economics significantly. So if we look at the history, well, the ultrasound has been around in medicine since 1942. The first time it was used was in 1958 when periarticular structures were studied, and the first joint beam mode picture was published in 1972, so that was about 50 years ago from now. And since then, we have come far, actually very far. So the top image on the right side is from 1972, and the second image is a few weeks ago from one of my patients. And you can see the difference in the clarity and the detail, and how high resolution pictures are, and how clearly you can demonstrate increased vascularity in a joint. And all that has been possible because of the improvement in the technology, improvement in the resolution screens, and better probes, matrix probes. We have tissue harmonic imaging available, and the future also looking into 3D reconstruction and 3D probes to create more detailed images. Not very much in clinical use at the moment, but that is not hopefully in the future. So the approach of a rheumatologist is slightly different from the radiological approach of scanning joints. So it is pretty much, in rheumatology we have to answer a single, simple question, and ultrasound can answer that question very effectively, very quickly, and in a very reliable way. And the question is there any inflammation? The examination usually is very targeted. We don't, if I've seen a patient with the right wrist swelling, I'm not going to look at the left wrist or MCPJs. I'll probably just focus on the affected joint, focus my scan, and get the answer that I'm looking for. So, and it is also very much problem-oriented. How patient is presenting. So if I'm looking for psoriatic arthritis, I will look at different joints and different areas. If I'm looking for rheumatoid arthritis, I will examine different areas. And finally, it is extremely efficient, as mentioned before. It also generates better patient satisfaction and better confidence of the physicians who are examining the patient in their own diagnosis. The overall scope of ultrasound rheumatology is quite wide. We use it both for diagnostic and therapeutic purposes. We can assess a wide array of things, like joints and tendons. We can do qualitative and quantitative assessment. We can do a scan of soft tissues. Blood vessels is a recent, not recent, but it's a more relatively recent addition in the assessment. And sometimes if you are proficient and you're comfortable using the probe, you might be able to get support of non-rheumatological diagnoses as So if we look at the key aspect, which is the diagnostic aspect of rheumatological ultrasound, there are three key areas that we are looking for. One is the arthritic disease or the joint disease. The second part is the non-arthritic disease, which includes soft tissues and connective tissue disease. And finally, the others, which includes intervention and looking for areas which are non-rheumatological. For joint disease, we have either an inflammatory joint disease, or we have crystal arthropathy, or we have a degenerative disease. And all these areas can be very simply and very easily identified with an ultrasound probe. When we're looking for inflammatory arthritis, we're looking for things like joint effusions, synovitis, presence of tenosynovitis, tendinitis, presence of erosions, whether they are active or non-active, and presence of rheumatoid nodules or other soft tissue swellings and inflammations around the joint. In crystal arthropathy, it is very easy to identify the presence of tophi and double contouring, which is a very specific sign for gout. And position of the erosions, periarticular erosions, are very suggestive of gout. Presence of chondrocalcinosis, which can be very easily picked up, and I'll later show you some examples, is another feature that it's quite specific for pseudogout. With degenerative disease, we can pick up loss of cartilage and osteophytes alongside other changes that can happen in degenerative joint disease. Looking at non-arthritic disease, mainly for vasculitis, it is becoming the gold standard for the diagnosis of giant cell arthritis and large vessel vasculitis. It has pretty much replaced the biopsy. We hardly ever perform biopsies anymore, and very rarely we would require a PET scan to look for large vessel inflammation. Most of the times we are able to diagnose this on the outside. Similarly, polymalgia rheumatica, the bursitis and presence of inflammatory changes around shoulders and pelvic girdle can be identified with the ultrasound very confidently, and it can support the diagnosis. Other things like mechanical tendinopathies, like tendon ruptures, sports injuries, ligament injuries, ultrasound is very good in picking these injuries. We can pick up neuromas, like motor neuromas, do interventions for them. Compressive neuropathies like carpal tunnel syndrome, ultrasound has a role in identification. And finally, in connective tissue disease, again, we're using it more and more to identify skin problems, especially since we have higher frequency probes, like 24 Hz probe. If you have our higher frequency probe, you can see skin so clearly that it is easy to identify. Again, I'll give you some examples in the future. For Sjogren's syndrome, assessment of salivary glands can assist in the diagnosis. And we had a long lecture about painful capilloscopy. Ultrasound doesn't replace that, but with 3D reconstruction, we can have a very detailed look at the structure and arrangement of the blood vessels and how many of them are there. So, a very useful tool in rheumatology. We are doing guided procedures. Various types, spinal injections, including epidurals, including passive joint injections. We do joint aspirations and injections, suprascapular nerve blocks, lateral cutaneous nerve blocks, knee blocks, hip blocks, muscle biopsies, and synovial biopsies. All can be done with the ultrasound guidance. And as mentioned before, that if there are diagnoses other than rheumatological problems which come from the differential diagnosis, especially giant cell arthritis, patients present with non-specific features like night sweats, fevers, weight loss, and you are looking for to exclude other problems alongside GCA, and balsam can be helpful on occasions because you might be able to identify the other cause which is leading to patient symptoms. Right, so we'll go through examples of pathology. So to start with, this is what we call a grayscale change. Grayscale change essentially is a depiction of swelling of the synovium or synovial hypertrophy. It is ideally, it is hypoechogenic. So in this area, this is the soft tissue of the skin. This is the normal echogenicity that we see. That's the top is the skin. On the top we have the starry side appearance of some gel. We can see an extensive tendon running all the way. And this is the joint surface. This is the metacarpal head, and this is the proximal phalanx. So this is a MCPJ that we're looking at, and we can see all this area appears darker, and that is a hypoechogenic appearance. It is not just darker, but we can see that there are areas which are not reflecting any signals, and this area is essentially most likely fluid. But what we're looking in the grayscale change is presence of soft tissue swelling, synovial hypertrophy, and this is a very classical example of synovial hypertrophy. The key thing is that it is only partially compressible or non-compressible. If there is fluid, the fluid is fully compressible. You put pressure on the probe and the fluid will disappear, while a synovial tissue, which is a swollen tissue, will not disappear. This example is of an elbow joint, and you can see again that this area is much darker as compared to the rest of the tissue, and this also shows increased Doppler activity in it. If we have to differentiate the hypoechogenic areas, whether it is a fluid or it's not fluid, and the two key things are the compressibility and presence of Doppler activity. So if it is a pure fluid, there would be no blood vessels going within it. So if there are no blood vessels going, you cannot get a Doppler signal inside that. If you are getting a Doppler signal inside the soft tissue, that is synovium or some kind of inflammatory tissue that we're looking into, and that is a very good example of synovial hypertrophy and grayscale change with superimposed Doppler activity. The third picture is of the wrist joint. So we have radius, lunate, capitate, and metacarpal with extensor joint tendon running on the top. And this area, which appears quite darker, is again synovial hypertrophy. You don't normally see this much thickening on the wrist. If this is present, this is highly suggestive of presence of inflammation. So this is the first thing that I'm looking for when I'm examining the joint, that is there a grayscale change or not. If there is no grayscale change, the chances of having active inflammation are low. We can still sometimes get increased Doppler activity without a grayscale change, but classically you want to see both. The second thing is the Doppler activity, and again here we can see this is one of the metacarpal phalangeal joints again, and metacarpal phalanx. This is the dorsal plate with the extensor tendon running on the top, and it clearly shows growth of blood vessels showing increased Doppler activity. Sometimes we can see Doppler activity within erosions. So this is an articular erosion on the joint surface, and you can see that there is growth of blood vessel inside, showing that this is actually active erosion. This is being damaged, the bone is being damaged as we see. And that area is really, if I see something like this, it really raises concerns and prompts me to escalate the treatment of the patient. This is the same in the transverse view. So whenever we see an erosion, we have to see it in two confirm that what we are looking is not an artifact. We can also find the increased Doppler activity around the tendons. This is an extensive ulnaris tendon, and we can see that within the synovium and within the tendon where there should be no blood vessels seen, we can see increased vascularity. Another feature of inflammation is presence of effusions, and here are a few examples. Again, key thing is compressibility. Where there is a fluid, it can be compressed. And second thing is that within the fluid, we will not see growth of blood vessels. This is a knee joint, and this is a patellar surface. Here we have femur, and this is the suprapatellar pouch, where there is a huge effusion, which can be seen, some extension of the soft tissue inside, which is visible. This is shoulder and bicep with swelling and fluid around the bicep tendon, and we can see a part of the subacromial subtemporal bursa with fluid in it. It's a patient who had polymild rheumatic, and you can see presence of fluid effusions there. Even around small tendons, if they are sufficiently inflamed, you can see presence of swelling. So extensive arterioidalis longus and brevis tendons showing presence of effusions on both sides. And finally, this is the olecranon bursa with fluid inside and some Doppler activity around it. So key things about effusions is that they are compressible, and within the effusion, you're not going to see any Doppler activity. Encephalopathy is a very important feature, and I think that is probably one of the most difficult things in rheumatology to assess, because the areas we're looking at are tiny and very difficult to image confidently. They're usually surrounded by normal vasculature, and the areas that we are mainly interested in is the insertion of extensive joint tendon into the distal phalanx, and insertion of flexor joint fundus tendon in the distal phalanx. Tiny areas, very, very useful in differentiating psoriatic arthritis from rheumatoid arthritis. If there is encephalopathy in these areas with relevant clinical history, you suspect that this is more psoriatic disease or HLA-A2 positive disease, HLA-A2 related disease, and not pure rheumatoid arthritis. So the other areas which show presence of inflammation are the Achilles tendon insertion and peripatellar insertion, so extensor of the knee, extensor mechanism insertion into the superior pole of the patella, inferior pole of the patella, or the reticular insertions on the lateral medial side of the patella. They show significant inflammation at times. Here are the examples of flexor deterred fundus insertion. That is the tendon pelvic, and here is an anisotropic, which Mars was explained very nicely, that you cannot see the tendon fibers there. It's not parallel, and so all the beam is being reflected away, not coming back to the probe. So we can't see this area, but we can see that there is a grayscale change around the tendon. And in addition, there is increased Doppler activity within that grayscale change. And that is classical of encephalopathy. That is, right at the insertion of the tendon, we are seeing inflammation. This is a beautiful example of psoriatic arthritis. This is distal phalanx extensor surface. This is the nail of the patient. So you can see how raised it is. Normally you would see 3 layers. So it's a trilanar structure. That structure is completely lost here. Usually it is smooth and straight, and again we see that how ribbed and rigid the nail is. extends to the pituitary tendon, coming and inserting into the distal pelvic space, and there is a large grayscale change around this area with increased ocular activity. That is what we see typically in psoriatic arthritis, suggests presence of inflammation. This is extensor carpi radialis and gravis tendon inserting, and again there is a grayscale change around that, as not shown in Doppler activity. And finally, this is the right quadricep tendon, which is inserting into the patella, showing presence of enthesophyte and some reduced echogenicity of the insertion, suggestive of presence of inflammation. Degenerative disease is easy. So this is an evidence node that we see in the distal interphalangeal joint. You can see the nail here a bit. The triangular structure of the nail is visible. This swelling is what we see in the evidence nodes on the skin. Usually that is what is visible outside. And these are the hook-like osteophytes with some sign of thickening, which is secondary inflammation. It's not primary inflammation. If you put in Doppler, you won't see a huge amount of Doppler activity, usually grade 1 to 2. But it is never overtly inflamed in pure osteoarthritis. This is a Bushmills node. So this is a BIPJ, and you can see that there are marked osteophytes there alongside the BIPJ with slight grayscale change, which is secondary inflammation rather than primary inflammation, and it shows presence of more degenerative type pattern rather than inflammatory pattern. Gout is usually a spot diagnosis if the genes are present. So you put your probe on and we know that this is gout. We're looking at presence of tophi, which appear as shiny bits around the joint and around the tendon. Here's a typical example. So these white shiny bits that we see around the synovium, they depict presence of tophi or early tophi, which is uric acid deposition in the soft tissue around the joint. Another thing we need to look at is for double contour signs. So that is the surface of the joint and TPJ, and on top of that we see another surface. Now that is unusual. If it is right there, usually there is a reflection from the surface of the cartilage, but here it is on a slope, and we can still see a very clear double contouring, which is classical of gout. It is not seen in any other condition. It can be seen artifactually, and sometimes it can be a bit difficult to differentiate this with chondrocalcinosis, but a classical double contour, you can never go wrong with that. Presence of acute inflammation, presence of periarticular erosions is another feature of gout. And finally, increased Doppler activity with double contouring in a specific area, especially the NTPJ, is highly suggestive of gout. Here are a few examples of chondrocalcinosis as opposed to gout. So chondrocalcinosis is deposition of crystals within the cartilage surface. So that is seen inside the cartilage. Gout deposition is on the surface of the cartilage, so you see double contour. Here what you see is that within the cartilage, this is the normal portion of the cartilage, you can see deposition of crystals. Similarly, that's how normal cartilage should look like. Dark and pretty much anapogenic, and there are echogenic areas within the cartilage showing the presence of CPT crystals. This is more closer to the bone. You cannot see a gap in the bone and the deposited crystals. Some of them are even generating shadows, and that is another feature of pseudogout. Classically, we see them more commonly in TFCC and in the knee joint. So So the triangular upper cartilage complex of the wrist and in the knee cartilage. These are a few examples of tendinopathy, which is seen in many conditions, different inflammatory disorders as well as non-inflammatory disorders. You can have mechanical tendinopathies associated with Achilles tendon, specifically, where is an example. This is from the same patient, tendon on one side, tendon on the other side, and you can see the difference. This is the width of the tendon on the normal side, and here is the width of the tendon in the abnormal side. You can see it is hypoergogenic, so it is suggested that there is some swelling going on, there is some fluid there. Increased Doppler activity with fluid, that is an extensive deterred tendon of the wrist, and normally you would see only 4 hyperergogenic dots with very thin amount of fluid or thickness of thickening of the extensor retinaculum around it. You can see large amount of fluid around it and a huge amount of increased Doppler activity suggestive of inflammation in this area. And the last example, both of them are from the tibialis posterior tendon, long and short axis, and you can see presence of fluid. The tendon otherwise is regular, and there is presence of fluid. You do not see much hypoergogenicity in the tendon here, which would raise the possibility that this is more of a mechanical problem rather than an inflammatory problem. So these are some interesting, this is scleroderma. So this is skin from the same patient in the normal area, and this is the sclerodermatous skin. You can see how smooth, thickened, and granular it appears as compared to the rest of the normal skin with prominent blood vessels. And it can be identified with the ultrasound. Do we need to do it? No, I don't think so. In this case, specifically, you could see it with your own eyes, so there was no real need. But if in doubt, ultrasound can assist you in making the decision. With Sjogren's syndrome, we can see increased Doppler activity with more irregular appearance of the parotid gland and active lymph nodes inside the glands, which suggest presence of Sjogren's syndrome. And finally, we are more and more using Doppler to assess Raynaud's phenomena and look for changes which might be associated with scleroderma and the nail fold categories. With 3D reconstruction, as you can see, this is a normal patient, by the way, that unfortunately I can't really show how it works because it's dynamic. So you can look into the tendon, you can move this around and see how the capillaries are arranged, whether they are making too many anastomoses or not, and how many of them are there few or there are more, and that can give you a very good idea if you're dealing with pathology or you're dealing with a normal subject. And finally, the intervention is another side of a rheumatological ultrasound. You can do joint aspirations and injections. This is a knee aspiration. You can see the knee going in, and that's done with direct vision. And a lot of time, again, the question is asked: do we really need ultrasound for aspiration injections? The answer is no. I was never trained. When I was trained, I never used ultrasound. I did them blindly. The word includes blindly. If I can see something, why would I do it blindly? So if I have a probe by my side and I can see where I'm putting the needle, why should I do it blindly? I don't think I should. So that's why I use ultrasound to look into where I'm going exactly and do things We don't need to know a huge amount of anatomy to decide whether somebody has inflammation or not. We don't need extreme details of knowing the physics of sonography or the anatomical variations. All we need to do is put a probe on the affected area and see if there are any signs of inflammation. And generally speaking, if there is inflammation, then the rest of it is dependent on the history and the distribution of that inflammation that will tell us what the problem is, and that tells us what the diagnosis is in a good number of patients. And that is a general scheme, a suggested scheme, which can sometimes be helpful. Most of the time, it can be helpful in deciding how to diagnose various rheumatological conditions with the ultrasound. We need to keep in mind that ultrasound is an aid to clinical examination. It does not replace history. It does not replace clinical examination. It is an additional thing. It's the stethoscope of a rheumatologist. We can put it on and we can confirm our findings. There is nothing more than that. If we purely rely on ultrasound to make diagnosis, that would not be possible. But with appropriate clinical history, with appropriate clinical examination, with appropriate tests, when we perform ultrasound, we are way more confident about our diagnosis than we would be otherwise. We can also quantify changes, and this is one of the schemes of grading the synovitis in rheumatology, for specifically for rheumatoid arthritis and inflammatory arthritis, and it has been divided into grade 0 to grade 3, both for grayscale changes and for Doppler changes. How important is it, practically speaking? If you are serially examining the patients, it is extremely important. So if I have a patient which I'm following up after initial diagnosis and I want to see whether there is an improvement after my treatment, this is very helpful in deciding that. This is semi-quantitative. This is not a true quantitative assessment because it still means, well, there's 50% involvement. You know, it involves your skill to decide whether there is inflammation or how much the grade is. There is another form of quantification, which is Doppler index, which is on the ultrasound system. It counts pixels for you. It is unfortunately not very reliable at the moment, but there is some research going on it to quantify it more accurately, and that might be able in the future to remove the assessor's bias to optimize the assessment in this regard, to quantify things. So, in summary, we have ultrasound as a very reliable and a very useful tool which can be used all across rheumatology, not just for joint inflammation, but for multiple pathological processes in their assessment. It is helpful both in qualitative and quantitative assessment of the joint disease, and it has a role in diagnosis, it has a role in monitoring, it has a role in rheumatological interventions, and I do not see that in the future we will be able to work without ultrasound. I think it's going to become an essential tool. It's already becoming an essential tool in rheumatology practice, and it is something that is going to be a must in the future. And this is one of the key areas of research in rheumatology at the moment as well, because we are relatively new to ultrasound. It's not new, it has been around for 50 years, but mostly it was being done in the radiology department, not by the rheumatologists. So from the rheumatology side, it has given a different perspective and a different approach towards assessment of the joint, and that is being researched quite thoroughly as we speak. That's it. Any questions?